devastating epidemic.
We just didn't know what to do. We just felt powerless. My parents' worst nightmare, to find my kid not breathing.
He was always very good at telling us, Mom and Dad, everything's gonna be fine. But it wasn't.
Addiction is ruining lives and ending them too soon.
Overdose is the #1 cause of death for people under 50.
We are racing against time.
Drug overdose rates climbed to an all-time high in 2017, accounting for 70,237 deaths. Of this, 47,600 were due to opioid overdose. With the death rates rising by 4.5 times what it was 20 years ago, this has become an epidemic to public health status.
Our mission is to highlight the way the public health system combats the opioid epidemic and the ways the system can be improved. Much like other issues, the public health system needs to be able to assess the problem, develop policy related to the problem, and make these changes as accessible as possible. But what are the parts of the system that does this? A big part in how the public health system addresses this issue is the organizational framework that is the actor in this problem, starting with those under the US government. The biggest governmental player is the US Department of Human Health Services, which does a lot of policy development with this, starting with the Support Act. The Support Act is important in putting restrictions on opioid prescriptions and controlling what is known as doctor shopping, switching physicians to get prescriptions. It also improves in informatics, in the monitoring systems for prescription drugs called PDMPs, and improves in the system to distribute medications that assist with treatment, or MATs, such as Nexalone. Under this, there are government organizations like SAM, HSA that expand on the distribution of MATs, as well as create grants that fund combating opioids in specific populations. Then there's the National Institutes of Health and the CDC. These work a lot in the research, surveying, data collection, and monitoring of the problem, as well as some work in suggesting policy. These are really the branches that function in assessment though. Biomedical and behavioral social sciences, biostatistics, and epidemiological surveying provide the research behind the problem. There are tons of private organizations, such as the American Medical Association and the American Society of Addiction Medicine, that support and participate in research studies and also lobbying to political officials. And then there are organizations like the Coalition to Stop Opioid Overdose that hold education awareness campaigns. Lots of these organizations' actions can overlap as well, an example being ASAM and COO both lobbying to Oklahoma representatives for policy development. Lastly, there are others that work in insurance and healthcare research services, like the Agency for Healthcare Research and Quality. And then there is action at the local and community level. This happens all across the nation, but we can look at a case example in rural Minnesota of how local governments and communities address this public health crisis. This specific NBCI article looks at the effects of 9 separate community outreach forums composed of local public officials and community leaders, as well as some of the policy development past year.
I think there are several levels of accountability at the manufacturing level and at the prescription level and at the educational level so people understand. I think everybody has to take part of it, and I'm doing everything I can to raise the awareness about it as well.
So what leads to the flaws in this system? Accountability can fail with providers or patients, whether overprescribing opioids or seeking opioids from a different physician. Still, the biggest problem is that they started out as a product for patients rather than something to control. The fallout of this being that adolescents and low-income individuals seek heroin for a cheaper, more covert transaction. The controversy then becomes, what's right for the patient? When does the patient's pain take precedence over the possible consequences? What can be done? Whether it's prevention treatments, policy change, or the public, there are many ways to take action.
There are numerous recommendations for how to improve the U.S. public health care system in regards to the opioid epidemic. One recommendation would be to increase access to treatment, which has been growing in recent years but still remains limited. From 2004 to 2013, only 1/5 of people with opioid use disorder received treatment. This would be an example of a tertiary prevention strategy. Admissions-level data on drug treatment programs show that from 2005 to 2015, only 1/4 of patients received opioid agonist treatment, for example methadone or buprenorphine, which is the treatment option best supported by clinical evidence. A second recommendation is to frame the opioid crisis as a public health issue instead of using the war on drugs approach or blaming the individual themselves. The war on drugs approach is not effective because it increases arrests, and it has been found that incarceration to deter drug use and distribution have long-term scarring effects on many communities, primarily those of color. Also, defining drug use as an individual's moral failing that can be remedied through willpower alone is inconsistent with biological triggers that create susceptibility to addiction. The ecological models of health behavior suggest a new public health approach to drugs that draws attention to multiple determinants of drug use and emphasizes the role of upstream factors that drive addiction, overdose, and associated social outcomes. It is important to address the forces that drive opioid use, the context of drug use, and the factors that make such use incredibly lethal.
One last recommendation is to increase focus and research on not only non-medical users, but medical users as well. Along with this comes safer prescribing, which is a primary prevention strategy so that less individuals are exposed to opioids in the first place. Policymakers who focus solely on reducing non-medical use are failing to appreciate the high opioid-related morbidity and mortality in pain patients receiving opioid prescriptions for medical purposes. Even though our population of individuals falls mostly into the category of non-medical use opioids, death of older individuals from opioids is attributed to mainly medical use, and we should attempt to limit this among all populations. Studies also show that many patients on long-term opioids for medical use worry about dependence and addiction and express a desire to taper or cease opioid therapy. This recommendation was also supported by the New York City Department of Health and Mental Hygiene when they released emergency room guidelines on opioid prescribing in 2013. Recommendations included in the guidelines call for substituting non-opioid analgesics when possible, avoiding use of extended-release opioids, and limiting the supply to 3 days. While the opioid epidemic is bigger than any one of us, we all have a responsibility to help. You can help by working to end the stigma, writing to your congressperson, signing petitions, and following campaigns. Please follow these links to learn more about easy ways that you can help end the opioid epidemic.